And now we're going to turn to our clinical topic. And Randy, this is your 17th appearance on this webinar. It doesn't just break the records, it shatters them. This is the ultimate, most frequent lecture here, and that's because everybody loves hearing your information. Everybody loves what you bring to the table. Dr. Randy Resnik is the director of the Resnik Implant Institute, which is the premier implant training program in the United States. He's the author of 2 recent textbooks. He's a frequent contributor to Chairside Magazine and other journals. And you know, if you ever want the most current information, just go to our website and type his name in. All these articles he's written about occlusion and bone grafting, they're all on that website, and they're great. His topic today is peri-implant disease, and he's going to approach it from the restorative direction, which I think is really interesting. I haven't heard a lecture that took it in this particular direction. So I'm going to turn it over now to Dr. Randolph Resnik for peri-implant disease, how prosthesis design is a contributing factor. Take it away, Randy.
Thank you again, Neil. It's always great to be back. I have a lot of information, so I'm going to go delve right into it. This topic is a topic that not too many people talk about from the podium. Peri-implant disease, however, from a prosthetic standpoint, how the prosthesis actually causes peri-implant disease, and we're starting to see some new studies coming into the literature that really shows a high incidence of the prosthesis causing these issues. Before we get into how this actually happens, you have to understand there are 2 types of peri-implant disease. There is perimucositis and peri-implantitis. Perimucositis is tissue inflammation, but it also has bone loss, or no bone loss, I'm sorry. And it's similar to in the natural dentition with gingivitis, whereas peri-implantitis is still tissue inflammation, but there is bone loss, and it's similar to periodontitis in the natural dentition. So if we look at studies, and I always pull the meta-analysis and the systemic reviews, these are the very good overall reviews of this subject. What is the incidence or the prevalence of perimucositis? And here I've listed the 4 of them here, probably the best ones out there in the literature: 65%, 47, 43, and once even 80% of the prostheses end up with perimucositis, which is very, very high. If we look at peri-implantitis, where there's actual bone loss, all these meta-analysis studies are coming back about 20%, which is rather significant, meaning 1 out of 5 of your patients that you treat with implants is going to end up with peri-implant disease. So this is something that we're going to have to really contend with in the future on how to treat this, how to prevent it better, because it is becoming a real problem. As I said, very few people talk about it, and that's why I thought this would be a great lecture to give, just to open up everyone's eyes on how this actually occurs. So if we look in the literature, who is predisposed to peri-implant disease? Well, I pulled all the articles. I have 11 different variables or factors which increase the rate of peri-implant disease. If I look at those 11, there is 7 of those that are directly related to the prosthesis. So that is rather significant. So what I'm going to do is kind of do an overview. I know I only have 45 minutes, so I'm just going to do an overview of how this happens, and I'm going to give you some take-home messages that you can take back to your office so you can prevent this on your next implant case. So if we look at what I call prosthesis-induced peri-implant disease, it all starts with biofilm accumulation, and then there are different aspects of the pathogenesis of this. So first, we're going to talk about the prosthesis design, specifically with the emergence profile, transition line, intaglio surface, prosthesis flanges, and then embrasure spaces. I'm going to show you how you can design these prostheses differently to prevent peri-implant disease. Then I'll talk about other factors such as implant positioning, prosthesis material. There's good materials, there's bad materials that will end up causing this problem. And then we'll end up with hygiene and maintenance. And I have some really good studies that will really amaze you on what happens after patients get these prostheses. So the first topic I'm going to talk about is prosthesis-induced peri-implant disease, the pathogenesis, so you can understand exactly how this works. Well, as you know, our oral cavity, we're full of microorganisms, and they secrete a pellicle formation, which adheres to the prosthesis surface. Once there's a pellicle formation, then if that is not removed, that bacteria colonizes and forms what we call biofilm. The most common biofilm that we know of is plaque. And that plaque or other debris that colonizes on the surface, it will have a strong affinity for many types of prostheses. And I'll go through those at the very end. So that is how this actually works. So if this biofilm is not removed, that leads right to peri-implant disease. So what do some of the studies show? Well, there's a whole slew of studies that show there's a high affinity for biofilm on prostheses, whether it's a all-on-X full arch or a single implant that some of the threads become exposed. So it does have a high affinity and it has to be removed. Biofilm forms within 24 hours. The most common bacteria that is super gingival is gram-positive bacteria, and that's streptococci. They also colonize Candida. So we do get a fungal growth on these also, which complicates the situation. So if this is not removed, it leads to the peri-implant disease. So how do actual prostheses increase the chances of this? Well, if we look at the design, so first of all, porosity. As we know, porosity will increase adhesion and colonization of any type of bacteria. And then we throw in depressions where the bacteria can hide to where the patient can't get in and clean. So these two types of prosthesis, you can see here all the bacteria because it's not self-cleaning and the patient can't even get in and clean. Whereas this one is fabricated to prevent that. So there is minimal porosity and there's no real depressions to cause a problem. So let's go right into prosthesis design, how that actually plays a part in this. Whenever we end up with a prosthesis that is over-contoured or under-contoured, it is what we call an atypical prosthesis. Yes, the lab can do wonders when the implant's in the wrong position and they can get a contact area on an adjacent tooth or an occlusal contact on the opposing occlusion. However, it does cause problems. How does it cause problems? Well, let's say this crown here is over-contoured. What that does is the over-contoured part of the crown pushes the tissue apically, and then you get instant tissue inflammation. So that is perimucositis. Perimucositis then goes right into peri-implantitis because why? The patient can't get in and clean. So you can see this crown, how it's impeding the patient's ability to get in and utilize proper hygiene. So if you look at crowns, and if you start looking at some of the crowns that even ones that come in from other offices, you're going to see some there's very atypical prostheses that are very, very over-contoured and is just a reservoir for plaque and biofilm. Now, if we look at the other opposite way is the under-contouring, we still get tissue inflammation, but how does that happen? Because we have under-contouring, we have excess tissue here. And when you get excess tissue, again, the prosthesis, because the implant is usually smaller than the tooth that it's restored from, is very difficult to get in there and evaluate it, whether you're probing or you're trying to clean. So either an over or an under contoured prosthesis will cause problems and lead to peri-implant disease. So if we look at, okay, so I have an implant. How do I design the best contour? What is the ideal prosthetic design? Well, if you look at the literature, there's conflicting research. There's a lot of variables that come into play. So I'm going to give you a kind of a summary. If we look at natural teeth, we were all taught in dental school, Wheeler's textbook on dental anatomy, 1960s. He came up with what is called the food deflection theory. And basically what he said is teeth are all designed basically with a convexity here, and that is to push away any food debris or any debris that could get into the gingiva. So the crown contours were designed to protect the gingiva with slight concavities in the cervical third of the tooth, and it is to deflect away from the gingiva. Well, that led to the emergence of the term emergence profile. So when we talk about emergence profile, that is basically used for prostheses. And the definition is the contour of the tooth or the crown as it emerges from the soft tissue. There's also an emergence angle that actually calculates angle. Profile is the more important term or the most utilized term. So if we look at teeth, teeth are self-cleaning, cleansing. They're easy to clean for most patients. What is the ideal emergence profile? Is it convex? Is it concave? Or is it straight? Kroll in the 80s evaluated that, and he did multiple studies. And what he came up with, natural teeth have a straight emergence profile. So when we look at implants, that came in probably the early 2000s. We want to start making straight emergence profiles with implants. However, that's not easy. But let's first look at why the emergence profile is so important. Well, number one, it maintains the gingival health here. It prevents any biofilm or retaining areas that could basically act as a reservoir for bacteria. It allows for maintenance that you can get in, and aesthetically, it makes the tooth look better. So when we look at that and try to extrapolate that over into an implant, there's some problems. And what are those problems? Well, first of all, if we look at the emergence profile of an implant, it's going to be a lot different than a natural tooth. Why is that? Number one, an implant diameter is round, it's circular, whereas a tooth is in the anterior, it's more triangular, it's more rectangle in the posterior. So a implant will never replicate the design of a natural tooth. So if you take a cross section of a tooth that's a cervical area, it will never be the same as a actual implant. Then we throw in the variable of implant position. That is if the implant is ideally placed. Let's say that it's a little lingual. Let's say it's a little buccal or mesial or distal. That throws off the emergence profile. Then we have platforms. Is it a platform switching or is it a platform matching implant? So there's a lot of variables, and I'll explain what the current literature states. So implants, if we look at should we have a convex, should we have a concave, or should we have a straight? What is the most ideal to prevent peri-implant disease? Well, if we look at the literature, Sue in 2010 actually renamed the emergence profile for an implant into two zones. One is called the critical contour, and the second is called a subcritical contour. And what actually is that? The subcritical contour is basically this apical area, and it's made to support the soft tissue, is where the critical contour influences the gingival level and the gingival zenith. So these two actually come into play. It's not just one emergence profile, but there's multiple components to it. And what Sue did in all of his studies found out that when you come off of the implant, ideally it should be a little bit concave. If you come off with it being convex, then that pushes the tissue away and the patient can get in it and clean it. and also that develops into peri-implant disease. So his recommendation was through studies, you want it concave right off the bat, similar to this. So this is a critical contour. This is the subcritical contour, which is the apical component. And then what his studies found is if there's a space there, then you actually get regeneration of the tissue there, and it will actually heal to the prosthesis. So it's almost developing your soft tissue drape via the prosthesis. And that usually takes about a month to 6 weeks. So if we look at this critical and subcritical contour area, what problems do we have with it? Well, not all implants are placed at the ideal position. We know that the implant neck should be 3 millimeters below the free gingival margin of the adjacent tooth. That is ideal. How about if it is 5 or 6 millimeters below? Now we have an excessive depth. Now we have an excessive critical contour. Same with if it's insufficient depth. So now we can't build the contour because we don't have enough room. And this is where the theory came many, many years ago about running room. Many of you probably heard about this, where there was a school of thought that you just bury the implant not 3 millimeters below the free gingival margin, but 5, 7 millimeters, and that allows you to build this critical, subcritical contour and or emergence profile. But what ends up happening when you have excessive depth, the bone on the mesial of this tooth, the distal of this tooth and the mesial of this tooth will actually remodel to the neck of the implant. So now we cause a black triangle and a periodontal problem on the adjacent teeth. So that's why the running room really came and went and really hasn't been well accepted. So later in a couple of years ago, Gomez came up with, and he further looked at this critical contour area, and he came up with 3 different zones. The C zone is straight, the B is concave, and the E is convex. Now, what does that mean? Well, the C is straight because when you're coming off of an implant, especially with platform switching, which is highly advisable because that gives you a better seal here anyway, this straight about at 1 millimeter is where the connective tissue is going to be. Right above that is there's going to be a small concave area where the junctional epithelium, and that's usually 1 to 2 millimeters. Then the E position, where the contour is convex, and that's for your sulcular epithelium, and that is usually 1 to 1.5 millimeters. So let's look at this on an actual tooth. So if you look at this green here, that is the straight, that is coming right off of the implant. That's similar to what a natural tooth is. However, we have to make up for the discrepancy between the diameter, the cervical diameter of the natural tooth, and the implant that we placed, which is always going to be smaller. So we need a little bit of a concave area because we have to get the buccal aspect of the tooth for aesthetics and for lip support. And then we have the very end, which is the E zone, which is convex, and that is to support the free gingival margin. So this is been postulated to be the ideal emergence profile, where it is straight, concave, and convex, a lot different than a natural tooth. So how do we develop this ideal emergence profile or critical contour? Well, first of all, we have to look at the implant diameter. So here I have from Wheeler's textbook, mesial distal buccolingually, the average diameter at the cervical area. And ideally, that implant should be as close to that measurement as possible. However, we have to take into consideration, again, the outline form of the natural tooth is a lot different than the implant. However, for, say, a central incisor, which is 7 by 6, certainly don't want to be doing a 3 millimeter implant there, because then that is going to throw off that emergence profile significantly. So the bottom line is the implant diameter should correlate to the tooth diameter as close as possible. Secondly, and probably even more important, is ideal positioning, because if we don't get the implant in the ideal position, or we don't treatment plan it right, then we'll end up with a huge discrepancy between this emergence profile and the contours. And that leads for the biofilm accumulation and the peri-implant disease. So we want ideal positioning, which is 1.5 millimeters apically to crestally, implant to implant at least 3 millimeters, and vertically 3 millimeters below the free gingival margin. So that is emergence profiles. Now, let's change and go into more of a full arch prosthesis. And let me tell you the latest on full arch prosthesis, because they are so popular anymore. So what is the most ideal transition line? Well, first of all, you have to know what the transition line is. That's the junction of the prosthesis and the edentulous ridge tissue. It's also in the literature termed prosthesis tissue junction. But this transition line has a lot of importance to the development of peri-implant disease. Meaning, is that transition line a passive contact where the prosthesis just lightly touches the tissue? Is it completely open where there's a space? Or is it completely closed, what we call ridge lap? Well, if we look at an open, which if you look back at the Brandmark studies in the Brandmark research, they found this to be the best because it was easy to clean. In fact, it was self-cleaning. However, patients don't accept this, especially on the maxilla. Why? Saliva pools there, speech, you'll get hissing sounds, you'll get food accumulation in there. So most patients don't accept that today, for obvious reasons why. If it is a open or if it's a closed transition line and it is a ridge lap, this happens when the implant here is placed more lingually than the facial contour of the tooth, meaning bone resorbs from buccal to lingual, the implant is more lingual, we have the crown because we have to support the soft tissues, and for occlusion, we have to build it out to the facial. That ends up with this ridge lap, and this ridge lap becomes problematic. That is in the anterior. In the posterior, the bone resorbs from buccal to lingual, that results in a lot of the implants being more lingually placed, but we don't want to put the patient in crossbite, so we build out that buccal corridor, and now we end up with a ridge lap. So no ridge lap. Ideally, it should be a passive contact with the ridge. Now let's talk about the intaglio surface contours. The intaglio surface definition is it's the part of the prosthesis that contacts the soft tissue. So what should the ideal intaglio surface be? Well, as I said, we see a lot of these ridge laps because why? They're aesthetic. The patient, when they smile, they're not going to show any of their own tissue. But what it ends up becoming, it's over contoured. It's a food trap. Food will get up underneath here, and it is non-cleansable. And a lot of times it's impossible for the patient to clean. You, as a practitioner, can't even get in and evaluate the implant because of the over contouring of the prosthesis. So here we're trying to even probe an implant. You can't get a probe even near that implant neck. So what do I see is the most common problem? It's a concave intaglio surface. And what it is, it's scooped out here because it is food debris will just deposit here, and it becomes very difficult for the patient to clean. So a concave intaglio surface is the worst thing that you can have. What you want is a convex. A convex intaglio surface will give you that passive touch. It's almost like an ovate ponic, and it will allow the patient to get in and clean. And if they get in and clean, then you're going to have less chance of a peri-implant disease problem. So ideally, the intaglio surface should be convex. It should be highly polished or glazed, and it should have no depressions where bacteria or anything can colonize. So again, convex is what we want on these full arch prostheses. Now, let me tell you another problem that we see on these full arch prostheses. With a ridge lap, you have a flange, which is the extension of the prosthesis to cover up that patient's tissue. So when we see this, it's usually always associated with a concave integular surface. We'll see this area that's basically a flange that prevents the patient from getting in and cleaning. So if we look at a convex, this is ideal. See how this integular surface is nice and convex? And I just ran a piece of floss over it to simulate what a patient would do. So if a patient puts in floss in between two implants, they're going to be able to very easily clean in between those two areas because it's convex. However, if it's concave, this is what happens. The bacteria sits there and it just accumulates and it colonizes and becomes basically a calculus bridge. So if I do the same scenario with the floss on a concave, look at this opening. Hopefully you can see that where here's the flange, here's a pseudo flange. The floss, if the patient flosses, they'll never ever be able to get in and clean. And that's why we're seeing so many problems with these fixed prostheses. Here's another one where the implants failed. Implants placed too far lingual. It's a huge ridge lap. And here you can actually see the depression in the tissue when we took the implants out. So what does that mean? That means that patient, there is no way they can get in there and clean. And you can see here's food debris prior to this procedure. So this ridge lap is a precursor to the peri-implant disease, and it becomes really problematic. Another area that I see is on the facial aspect of the MUAs, the multi-unit abutments. A lot of labs will end up putting this little flange here. Okay, what that means is the patient, first of all, you'll never be able to get in and evaluate at the neck of the implant. But secondly, the patient will never be able to clean that. What you want is a nice convex transition from the actual prosthesis to the cervical area of the abutment. So no flanges, similar to what I had just shown you. Okay, let's move on. Embrasure space. Now, embrasure space is usually used as a term with natural teeth. Basically, it's the V-shaped area between natural teeth. But there's also embrasure areas on a prosthesis where there's an opening. And this is what I want you to take home from this. Here's a prosthesis, comes back from the lab. There's no embrasure area. There's no way that this patient would ever be able to even know where the implants are to put floss in to clean it. So because of the ridge lap, there is no embrasure. So this is after it's modified. So a sluice way is put in between the implants. It's still kept basically convex, but the embrasures are put in. So when you go ahead and put this in the patient's mouth, now the patient knows where they have to get in to access between those implants. Now, unfortunately, with zirconia implants, it's not easy to modify these prostheses. When you do, you have to send it back for restaining and reglazing. So ideally, you should have a small little embrasure space so the patient knows they'll know exactly where they are and how to access those. Okay, that is with implant design. Now let's go in the implant positioning. And I'm just going to go over this briefly just because of time issues. But implants, if they're not placed in the ideal position, you end up with an atypical prosthesis. You as a restorative dentist now jump on the train that's out of control, and you become part of the problem when the patient starts to lose bone and starts to develop peri-implant disease because it is your prosthesis that you're putting in that the patient cannot clean. And the design of these is just not ideal. But unfortunately, unless the implant is repositioned and replaced, this is something that's just going to happen. So you as a clinician have to decide, is it in your best interest to restore it, or is it better to take the implant out and have another implant placed in the ideal position so that you can have an ideal prosthesis form? So in every state in this country, the state dental laws and the statutes state that when you put in a prosthesis, it has to be cleansable. So it's actually a deviation from the standard of care if you put a prosthesis in that cannot be clean. So you have to be very, very careful on that. Remember, you don't have to treat any patient that you don't want to. So if this is a perfect reason, the implants are not in the ideal position, just don't put yourself at risk. Here's an AP spread issue. Here is a fixed prosthesis where the implant, the ridge, the discrepancy of the ridge where the teeth are is rather significant. And you can see it by the green arrows here. So here's where the implants are. Here's where the incisal edge is. This is one big ridge lap. So it's almost impossible for this patient to get in and clean. And that is basically from the design of the prosthesis because of implant positioning. I see a lot of these bars, especially in the maxilla. Why? Because with the bar, you need a lot more room. We know that you need upwards sometimes of 15 millimeters of restorative space for a bar, but you always have to have 1 to 2 millimeters below the bar that it can be cleansable. So what do we see? We see these bars that are basically countersunk into the soft tissue. So then what happens is the patient gets gingival hyperplasia, and now it becomes a perimucositis, which easily turns into a peri-implantitis. So again, the implant position, more of an osteoplasty or alveolectomy should have been completed, where the implants are put more apically so that there's more room for the bar and the abutments. Now, prosthesis material. There are all types of materials. There's a lot of research on this. Everyone has their favorite material, but let me tell you what the literature states now. If we look at zirconia, zirconia is at the top of the list. Monolithic zirconia. If you look at this study, it looked at zirconia versus porcelain. Surface coating was a mere fraction of it compared to what's on porcelain. But what's even more significant is the biofilm thickness. With zirconia, you don't get the thicker biofilm like you get on porcelain and other materials. If we look at this study, zirconia had the lowest amount of biofilm accumulation, and I should stipulate that is highly polished zirconia. So if you adjust it and you don't polish it, it's going to be similar to porcelain and or acrylic. So you have to make sure that it's polished. Glidewell has a very nice zirconia polishing kit, and I highly recommend you use that anytime you do adjust it. If we look at other studies, here is surface porosity. As I said earlier, we need porosity for that helical formation, which allows the biofilm to adhere to. So if we look at the lowest porosity, it's zirconia. Highest is going to be acrylic. And acrylic is a problematic. And why is that? Because we're getting more of these 3D printed prostheses. Even though a lot of them are interim, these nanoceramics are more porous than the zirconia. So you have to be very careful. So when you're using these 3D printable prostheses, what you must do is use the glaze. You should glaze it so that it doesn't have the porosity. So make sure that you glaze it. If you have to alter it, then you send it back and go ahead and have it glazed again, because the highly polished, higher glazed material is not going to allow that bioform formation to occur. And lastly, the home care and maintenance. First of all, poor patient hygiene. How does that come into play? Well, here's a study that shows 42% of patients feel anxiety regarding cleaning their implants. They believe that they don't have teeth anymore. They don't need to clean. So this doesn't matter to them and they don't clean. That is rather high and rather alarming. What else is alarming is if they have good home care, that's every 8 to 12 hours, it eliminates 85% of the biofilm just with the patient. So if the patient does have good home care, and that's what you have to really explain to the patient and educate them on this. Here's a good study on accessibility. What this study looked at is prostheses. Is it accessible to clean or is it not cleansable? And what they found out is the prostheses the patients couldn't clean or had difficulty. 48% of those implant cases ended up with peri-implantitis, whereas when patients had easy access to it, only 4. So that just is an alarming study that shows how important it is to have an open prosthesis. However, because aesthetics has taken over so much of dentistry and everyone wants to please the patient, and the labs put ridge laps on here because they don't want doctors sending it back to have it placed on later because the patient didn't like it, but you still have to clean. And that's why I highly recommend you have a education meeting with the patient to explain before you even start in this process exactly what they're getting themselves into and how they have to clean. Just remember this. When you have that concave and tag loose surface, which is probably the most common now that labs make, you can't clean it. It's impossible. So how do you clean it? Well, we'll talk about that in a second. Let's talk about professional maintenance. So here's a study that looked at regular versus no maintenance by the dentist. Implant failure was 90% lower in patients who had regular maintenance therapy, whether it's 1 month, 3 months, 6 months. Here's another study that looked at no maintenance. Developing peri-implantitis was 11-fold, which is rather significant. Here is a study that they looked at age groups. And what they found is patients, I don't know how they picked 29, but they found that 29 and younger had the highest discontinuation rate for coming in and having implant maintenance. So those are just some of the studies out there. So what is the recommendation? Well, for these full arch prostheses, especially if you have ridge laps, there's nothing better than a water irrigation system, water pick. Here's a study that looked at bleeding reduction around implants. 81% reduction with an oral irrigator. With floss, it was only 33. Why is that? Because if we go back to this and we look at this, no matter how that patient flosses, they'll never clean it. So they have to get the debris out. Now, the problem is, even though these water irrigation devices are very good, they still don't do the job 100%. So I always get the question, Randy, should I remove every prosthesis at every hygiene appointment? And I'll give you, there's very little research on this, but let me tell you what some of the positions are out there. First of all, having patients come in and taking the composite, the PTFE tape out or the cotton, and then removing every screw is very difficult and it is very time consuming. So the disadvantage of doing this is it's time consuming. The second disadvantage is the screws. And a lot of people don't realize this about the screws. The screws basically are usually made for one-time use. So changing out the screws, if you take a poll of implantologists, 50% change them out, 50% don't when they remove a prosthesis. So what does the ACP, American College of Prosthodontists, state? They say because of the screw issue and the difficulty in removing these, that you only remove it if you have diseased gingiva, diseased implants, or if the prosthesis is so atypical that the patient can't clean it. So you have to understand about these screws. What is the engineering basis behind these screws? So when you take a screw and you put it into the implant, basically you're torquing it. And when you torque in that, as it tightens, those threads elongate and that produces tension. That tension is called a preload. And that preload is the force that's built up in here to hold that prosthesis on. Unfortunately, it relaxes a little bit and then it's called the clamping force. But this implant screw is the same in engineering as what is called a bolt joint compound, bolt joint connection. So it's what every parking lot light and street light, they're held up with these bolts. And what happens when they torque the bolts, what it holds under this torquing force or preload, whatever they're cantilevering or whatever is being held up. But these implant screws are the same. So this is a case from my son Christopher where a implant was removed and the screws got loose and it came in and the patient was having the screw tightened multiple times by another dentist. Ends up in my son's office, he takes it off and you can see where the screws actually deformed from taking the prosthesis off, cleaning it, putting it back on. So the bottom line is these screws, when you put them through this incremental torque and you put them in, they're made to be used once. Now, what is the bottom line? There is really no study out there that tells you that you can remove them and replace them 1, 2, 3 times. The problem is there is all screws are different. The pitch, the amount of threads, the thickness, the material differs. So you have to take all that into consideration. So I know right at 1 o'clock, so I have to end this. So the take-home messages from this lecture is we went over a lot here. This is probably about a 3-hour lecture that I gave you, but hopefully you understand prosthesis design, positioning, material, and the importance of maintenance. You should understand there's a high incidence of perimucositis and peri-implantitis. Every one of us is going to have to contend with this. Every one of us is going to have to know how to treat it and how to prevent it. Biofilm is the leading cause, and the reason is it attaches to the prosthesis. The contour, the design of the prosthesis is very important. You cannot simulate a tooth and a natural tooth in an implant. They are different entities, so you cannot use the same emergence profile. I talked about a subcritical and a critical contour. The subcritical has to be convex. It should not be, it should be concave. It should not be convex. The implant position is crucial as it will give you the atypical prosthesis. Transition line, be careful with having a ridge lap. You do not want a ridge lap because what that usually is associated with is a concave intaglio surface. When you have a ridge lap and a concave intaglio surface like this, there's no way for the patient to clean that. You want more of a passive contact like this, which is an ovate ponic. So no concavities and no flanges. Prosthesis materials, zirconia is the best, acrylic's the worst. Home care, crucial for longevity of the prosthesis. Okay, Neil, that might be a record. I got it done. Okay.
As always, you got it
yes.
done. That's great. We got some questions for you. That was a great lecture. I can't believe how much you packed into to that amount of time. Amazing. Okay, I'm going to just jump right into some questions here. So you talked a lot about the importance of hygiene in preventing peri-implant disease. Are we doing too many fixed full arch restorations as compared to overdentures that can be removed and cleaned?
Well, I mean, you've been in this profession as long as I have, Neil, and you know that it's gone back and forth. I'm going to say at least 4 times where fixes become popular, then overdentures, back fixed overdentures. Right now, we're in a significant fixed. I don't know if we're going back to overdentures, to be honest with you, because the patient acceptance. So if you look at studies, patient acceptance and aesthetic approval on fixed is increasing significantly compared to what we used to have back in the Brandemark days. So to answer your question, are we doing too much fixed? It's hard to say. It's just that's the flavor of the month right now, and everyone likes it. The problem, I think, is more, I think we're doing too many fixed on implants that are placed in non-ideal positions. And if the implant is placed in a more non-ideal position, it's easier to do an overdenture, a bar, and hide it with a removable prosthesis than to try to fix it with a fixed prosthesis.
Right, right. And of course, if you're in a situation where you're going to end up with some ridge lap, gee, that it would have been nice if that would have been removable too. That's so.
Exactly.
Let me ask you this. So, from the surgical perspective, what kinds of things should we be thinking about so we don't end up with a full arch fix that's got this mammoth ridge lap? Because I mean, when I see them coming to the lab, the doctors are requesting a ridge lap because they're trying to cover up that transition line, or maybe even move that transition line a little higher up.
Yes.
Using that flange.
And they do. So, I mean, I've asked many lab technicians, like, why do you put a ridge lap? And every time I ask someone that, they say the same exact thing. The doctors require it. If we don't put it on, they'll send it back to have it added on. So I think our education on this subject needs to be addressed. And that's why I put this lecture together, because I have this in the new textbook, and I go, no one talks about this, but I think lab technicians and clinicians also need to understand the ramifications of this. The peri-implant disease incidence studies are off the charts. And I mean, if we had that on natural teeth, I mean, periodontist, you wouldn't be able to get into a periodontist. But a lot of clinicians look the other way. It's implants. We're supposed to lose some bone, and we're supposed to have, bleeding tissue, whatever. So I think in the future, especially younger practitioners, they're going to have to address this because, as the implants are in the mouth longer, there's more complications and there's more peri-implant disease. And once you get perimucositis, it goes into bone loss, and there's not many very easy ways to reverse that to get that bone back over top of the implant.
Right. Yeah. I mean, it's interesting because your lecture addressed peri-implant disease from the restorative end, but a lot of the restorative problems are created in the surgery, right? Based on where the implant is positioned.
Exactly. And where I find that problematic is it's putting the restorative dentist at risk because they're putting the prosthesis on. Okay. So for instance, you do an all on 4 and you put a zirconia prosthesis in, and one of the implants fails because of this abnormal design. Well, you can always put another implant in. That's the cheap or the less costly part of it. But to rebuild the case prosthetically is very costly.
Exactly.
So,
exactly.
Yeah. So the restorative dentist has to be very careful.
Okay. And another issue from the lab end is that, a lot of times the lab is getting, let's say on a single tooth impression, they're getting a sulcus that's the same width as the impression coping, right? There's just been
Yes.
a healing abutment that's cylindrical. There's been no effort to train the tissue, and there's only so far that you can push that tissue out with the prosthesis. Do you have any recommendations? Is this something where we should be going ahead with a provisional and trying to build the tissue contours we want?
I mean, to be honest with you, if I was a lab technician, I would look at a lot of these impressions and just say, if you want to do the best service for your patient, would be to go back and put the patient in a provisional, develop a soft tissue drape. Once the soft tissue drape is ideal, then take an accurate impression. Okay. But some of the impressions, they don't even capture all the soft tissue. So then you're kind of just guessing. And, I think we're at a time in implant dentistry where it's shifted from, you know, where we used to call failure of an implant, that's where bone didn't grow around the implant. Now you can have an implant that has bone grown around it, but aesthetically it doesn't look good. And now it's a failure.
Right.
And to work backwards is very difficult. So that's why we always train everyone, put the implant ideally where it should be for the prosthesis. It should be a top-down treatment planning. You don't look where the bone is and say, here, I can put implants here, then I'll figure out how to put a prosthesis on. Find out where the incisal edge is first, then see, do I need bone grafting? Bone graft it so that you don't have these huge ridge laps or
Right.
these
And
problems.
to me, I think that's a great commercial for digitally guided implant surgery, right? Because
Definitely.
you're going to be able to take a look at it, and then you're going to be able to get that implant in the optimal position. I think that it all kind of goes together. Um, Another question, you mentioned these new printed nano ceramics, and you mentioned the importance of glazing them. Got a couple questions. I know my experience has been that most ceramic glazes are not long term, that they do tend to wear off. And then we had a doctor write in and said that he's seen issues of tissue irritation from the glaze on the intaglio surface. Have you looked at any
Yeah.
of those studies?
Actually, that's more my son's forte, the 3D printing and all that. I just know from the studies that they recommend the glazing. And yes, I do realize that they they do go and they wear off. But what's underneath, if they're not glazed, is a more porous prosthesis. So if you look at, say, acrylic or these resins or any of the nano ceramics, you look at them under an electron microscope, they're rather porous. So they're not like zirconia,
Right.
okay, where it is smooth. And that's why I put in those studies, Neil, of biofilm, even if it does form on monolithic zirconia, it's not real thick as it is on porcelain. And that's what porcelain, just think what acrylic, how much. And I showed some of those
Yeah.
images where it's just unbelievable.
No, and
And
it's interesting too because the printed ceramics are much more porous than regular ceramics, but the printed acrylics are actually less porous than the old style acrylic. So there's a lot of
yeah,
changes going on in those materials. It's very interesting. So thank you
okay,
again, Randy. It's been great to
okay.
have you on for the 17th time, and we really appreciate it. It was a great lecture again. I know we had a big group again today, so thank you so much, and we'll see you at the implant symposium, right?
Okay, thank you.
All right, take care. Bye bye.
Have a
Brandon.
good weekend.